Good evening. My name is Megan Glenn, and I am ALS National Senior Director of Programs. I'd like to be the first to welcome you to tonight's academic debates presented by the American Liver Foundation. We are excited about our topics, proud of our teams, grateful to our sponsors, and honored to have such an outstanding panel of judges alongside our esteemed moderator. We're grateful that you would take the time out of your busy schedules to join us and hope you enjoy the evening. Tonight's academic debate is being delivered on the Zoom webinar platform and will be recorded. During the presentations, if you have any questions, please hover your mouse over the bottom of your screen and click on Q&A. Then simply type your question into the Q&A box. For all other comments and to cheer on your favorite team, please use the Q&A box as well. Again, please note that this program is being recorded and will be available on ALF's YouTube channel for future viewing. As I mentioned earlier, we are extremely grateful for our ongoing sponsor support. We are so grateful to our premier supporter sponsors, AbbVie and ASI, for supporting the 2022 academic debates. Let's hear what our premier supporter sponsors have to say. We are so appreciative of our sponsor support. As I mentioned, we are so appreciative of our sponsor support. Without their support, we would not be able to continue to fulfill our mission. Before I introduce our moderator, I want to acknowledge tonight's technology team, Erica Bachter and Tyler Holderby. We wouldn't be able to present tonight's event without their expertise. Now it's time to turn the program over to our moderator for tonight, Dr. Shahar Taddy. Dr. Taddy is a professor of medicine and vice chief of faculty development in the section of digestive diseases at Yale School of Medicine. She is also a staff hepatologist at the VA Connecticut Healthcare System, where she directs a regional liver cancer program serving Southern New England's VA medical centers. She is a board-certified gastroenterologist with a certificate of added qualification in transplant hepatology. Her clinical interests include end-stage liver disease, liver transplantation, and liver cancer. Her research is focused on outcomes in clinical trials in cirrhosis and liver cancer. She is co-PI of Veterans Outcome and Costs Associated with Liver Disease, or VOCAL, study group, and the VA-funded SACRED trial. Tonight, Dr. Taddy will be saying a few words about the history and format of the debates. We'll explain how you can help support the mission of the American Liver Foundation, how you can promote the debates through our social media, and introduce our esteemed panel of judges for tonight's debates. Dr. Taddy?
Thanks, Megan, for the introduction. Well, I'm so happy to be here tonight, and I'd like to welcome everyone to this American Liver Foundation's Academic Debates Madness. So we have our own liver variety of March Madness. Academic debates have actually been hosted by the ALF for over 18 years. These debates have been recognized for educational excellence and have been a longstanding signature program of the American Liver Foundation. The debates are our most popular non-CME programs among healthcare professionals in various medical disciplines and fields. This year, we're engaging in a week-long March Madness of academic debates, which started on March 28th and concludes on April 1st. Each team will consist of 2 fellows and 1 mentor from nationally recognized institutions. Each individual debate will feature 3 judges and 1 moderator. The winning teams will be selected based on their research, as well as the presentation of both their cases and rebuttals. A medical advisory committee has set forth the specific subject matter and perspectives that each team must argue. The topics for this week's debates have been alcohol-related liver disease, autoimmune liver disease, fatty liver disease, liver cancer, pediatric liver disease, and viral hepatitis. So if you're just joining tonight, you're in for a treat. But if you've been listening all week, you've probably learned a ton. There are no right or wrong answers to the topics. They're chosen specifically in gray areas. And the different research evidence and perspectives presented often lead to invigorating discussions. We provide the criteria to the team members to focus on creating professional and well-researched PowerPoint presentations, practice and refine their rebuttal skills through research of their assigned topic and position, and be prepared to show how quickly they can think on their feet during the Q&A. Tonight, it's our pleasure to present 3 exciting debates featuring teams from Beth Israel Deaconess Medical Center, University of Cincinnati, Yale University, Emory University, Rush University, and Ascension Providence Hospital. The topics assigned to the debate teams are chosen specifically because they have not been settled in the medical literature or are either in nature with no wrong or right answer. Through these debates, we seek to stimulate higher thinking about significant issues that impact the lives of people with liver disease. The debates will be fast-paced. We will start each debate with the PRO presentation, followed by the pro presentation, followed by the opposing con presentation. Each side is allotted precisely 8 minutes to present their argument. Should a presenter exceed his or her 8 minutes, our diligent timekeeper will disconnect his or her audio and video. We'll do our best to transition smoothly from one presenter to the next to keep the program flowing. After both arguments have been presented, each side will have the opportunity to challenge their opposition, with a 5-minute rebuttal. Debate teams may not use slides during the rebuttals, and teams will be closely timed. A 5-minute Q&A session led by a panel of judges will follow the rebuttals. We would like to acknowledge the demanding work of our presenting teams and their mentors, and express our appreciation to our sponsors, judges, timekeepers, and technology teams. Importantly, we thank you for joining us tonight. The American Liver Foundation has been a trusted voice for liver patients for 46 years. Its leadership and staff always strive to ensure that the foundation is a reliable source for patients, caregivers, and medical professionals. Educational programming has been presented consistently to ensure that people have access to information about myriad liver disease topics. All programs are recorded and uploaded to our YouTube channel for easy access to people who want to view the programs again, or for availability for those who were not able to participate as they were occurring. Printed literature has been created and updated, as have our web pages about liver disease and transplant-related issues. All resources are available at no charge to the public. Our national helpline remains a vital source of assistance for people who want and need information about medical diagnostics, various liver diseases, and links to financial aid, patient and caregiver support, and more. Our ongoing advocacy efforts make certain that issues pertaining to access to care and treatment remain a priority for legislators who make important decisions about healthcare policies. Our walks, marathons, and patient and professional education programs are key components that unify the liver community. We cannot do any of our work without your generous support. ALF is a not-for-profit organization and as such relies on donations to carry out its mission. Please be as generous as possible tonight and help the ALF continue to provide resources to the patients and caregivers, the healthcare community, and the general public. Tonight's fundraising goal is set at $5,000. Any and all support is greatly appreciated. No amount is too small or too big. Before I introduce our topic and team members, it's my privilege to introduce our outstanding panel of judges. These judges will join us at the conclusion of each debate to ask thought-provoking questions of our debate teams. The outstanding panel of judges includes Dr. Andrew Keaveney. He's a transplant hepatologist and the medical director of the Mayo Clinic Florida Liver Transplant Program. His clinical focus includes assessment and management of patients with cirrhosis, management of the liver transplant recipient, application of non-invasive testing of liver fibrosis, and treatment of viral hepatitis. Dr. Keaveney is active in clinical research, focusing on novel therapies in portal hypertension, complications of cirrhosis, and outcomes after liver transplantation. He has authored numerous articles in peer-reviewed journals, edited a book on complications of cirrhosis, and is on several editorial boards. He's a member of the major professional societies that focus on liver disease and has served on several committees of the American Association for the Study of Liver Diseases. Dr. Tushar Patel is primarily focused on liver epithelial cell biology, with an emphasis on understanding the role and regulation of non-coding RNA genes in the pathogenesis of liver and biliary tract cancers. An area of emphasis is the study of cellular and molecular mechanisms by which dysregulation of cell survival signaling pathways contributes to disease pathogenesis in hepatobiliary cancers. He's particularly interested in the roles of extracellular vesicles and extracellular RNA in fundamental processes involved in liver cancers. In conjunction with the Extracellular RNA Communication Consortium, funded by the National Institutes of Health Common Fund, Dr. Patel and his group are exploring novel biomarkers. Based on this research, they're developing new treatments and exploring new paradigms of disease. Dr. Nikhil Kapila is a transplant hepatologist in the liver transplant program at Cleveland Clinic, Florida's Transplant Center. A board-certified gastroenterologist, Dr. Kapila specializes in liver and biliary tract diseases. His research interests include the treatment of liver and kidney transplant recipients receiving hepatitis C infected organs. Dr. Kapila completed a transplant hepatology fellowship at Duke University in Durham, North Carolina, following a fellowship in gastroenterology and hepatology at Cleveland Clinic, Florida in Weston. Let's go ahead and introduce the first debate. The key clinical question for the first debate of this evening is whether or not stable, unresectable intrahepatic cholangiocarcinoma should be offered MELD exception for transplant. The case study associated with this debate topic features a 55-year-old man with hepatitis C cirrhosis found to have a single 3-centimeter mass on ultrasound. CT scan did not show typical features for HCC. A biopsy of the lesion confirms cholangiocarcinoma. He's not felt to be a resection candidate on account of his cirrhosis. He undergoes Y90 and 3 months later has minimal viable cancer. He goes on chemotherapy and 3 months later, his imaging shows stable but viable disease. His CA19-9 is normal and has never been elevated. As a reminder, the pro presentation will be 8 minutes, followed by the con presentation of 8 minutes. Next, we will welcome each of our rebutters separately, and they will have 5 minutes to refute the opposing team's presentation. This will then be followed by the judges' Q&A. So debate topic number 1 is, should stable, unresectable intrahepatic cholangiocarcinoma be offered MELD exception points for transplant? So the pro team will be Beth Israel Deaconess Medical Center, and the con team will be University of Cincinnati. So now I'll go ahead and introduce our debate teams. So presenting the pro position that stable, unresectable intrahepatic cholangiocarcinoma should be offered MELD exception for transplant is being mentored by Dr. Zachary Fricker. The fellows are Dr. Rosa Yu and Dr. Aaron Hakim. So the University of Cincinnati is up front and will argue the con position. Stable, unresectable intrahepatic cholangiocarcinoma should not be offered MELD exception for transplant. Their mentor is Dr. Alex Chang, and the fellows representing the University of Cincinnati are Dr. Michelle Estrada and Dr. Sue Evans. Dr. Rosa Yu from Beth Israel Deaconess Medical Center will now present her position. You may begin when you have your slides and you're all set.
Hey everybody, let me pull up these slides. My name is Rosa Yu. I'm joined today by Dr. Hakim and Dr. Fricker. I'm really excited to be kicking off this debate. It's something we've been working really hard on. Thanks so much for the kind introductions. So as mentioned, we'll be defending the pro side that stable, unresectable intrahepatic cholangiocarcinoma should be offered MELD exception for transplant. In order to provide a framework and guide this discussion, we wanted to propose this way of thinking about our ideal candidate for liver transplant based on prior studies, as well as what we do currently in terms of standard of care. These components include 1, high mortality with the natural history of underlying disease. Number 2, that liver transplant is likely to improve survival. Number 3, that expected absolute survival benefit post-liver transplant approaches that of other liver transplant indications for hepatobiliary malignancies. And 4, that expected relative survival benefit over current standard of care matches or exceeds other liver transplant indications. As we continue through this discussion, we'll refer back to this framework. We wanted to first start by talking about the high mortality of intrahepatic cholangiocarcinoma. Initial studies of large databases demonstrate that the 5-year overall survival of iCCA is below 5%. This is, of course, including all types of iCCA, and getting more granular to our particular discussion topic, looking only at liver-only unresectable iCCA treated with first-line chemotherapy, the median overall survival was only found to be 16.7 months. Even looking at the upper bound of the 95% confidence interval, this only goes up to 20.2 months, and the 5-year survival is 0%. Looking at a wider database of stage 1 unresectable iCCA with or without chemotherapy in the SEER database, the median overall survival is about 7 months with a 5-year overall survival of 8%. Unresectable iCCA, as in our patient, carries with it significant morbidity and mortality. And so we believe that this fulfills the first framework of what makes these patients a really ideal candidate for liver transplant. The next natural question is to understand whether or not liver transplant is likely to improve survival in these patients. And so we wanted to start by talking about the best data that exists out there right now, which is with prospective trials. So this was a trial done by Lunsford, published in the Lancet in 2018. And here they selected patients with locally advanced intrahepatic cholangiocarcinoma that was not amenable to surgical resection. These patients demonstrated pre-transplant disease stability on neoadjuvant therapy, and the investigators strove to see if these patients would benefit from liver transplantation. So this matches our case exactly. And in fact, we actually believe that the patients that they selected for this, for liver transplantation in this case, actually were sicker than our patient in this proposed case. In essence, we're trying to answer the question of whether or not stable disease after neoadjuvant therapy can effectively select for favorable biology and ideal patients for liver transplantation. In this particular case, with unresectable iCCA, the cumulative tumor diameter was actually 8 to 17.9 centimeters. So this is significantly more than in our patient who has an isolated lesion that's only 3 centimeters in size. In these particular patients, they had multifocal disease, so between 2 and 10 lesions. And in this case, there was really, the findings were absolutely remarkable. Even with large advanced iCCA and multifocal disease, the overall post-liver transplant survival was 100% at 1 year, 83.3% at 3 years, and at 5 years. Absolutely remarkable. We noticed that the confidence interval is quite broad because they were incredibly selective, and so the N was slightly smaller, but this really shows that we can really consider liver transplant in these patients to improve survival. Recognizing that this was a smaller sample study, we looked at an additional study, which is also, again, a prospective trial by McMillan et al. This was published more recently in the American Journal of Transplantation in 2021. And in this case, the N was 32 patients with unresectable iCCA. Again, the tumor diameter cumulatively was between 8 and 18 centimeters, so significantly larger than our patient. And many of these patients also had multifocal disease. Notably, they had stable disease on gemcitabine, and they were listed. And what we find in this large cohort is that the 1 year survival was 100%, and the 5 year survival was nearing 60%. We again emphasize that these patients did remarkably well, and this is really an incredible benefit. It's an incredible benefit as compared with the alternative, which is really poor overall survival over 5 years. Looking through all of this, I think what makes these two studies incredibly successful is how selective they were with the patients that they chose. We don't argue that every single patient with intrahepatic cholangiocarcinoma would be a good fit for liver transplant, but in the perfect patient who can be offered a MELD exception, I think these patients can do remarkably well. And it comes down to many of the same factors that we consider for transplantation, including patient factors, so those with minimal comorbidities, and really key disease factors, which our patient fulfills. So an unresectable tumor that's less than or equal to 3 centimeters, locally advanced disease in the liver without extrahepatic metastases or vascular invasion, favorable genetics, moderate tumor differentiation, disease stability for 6 months, ideally more, and response to downstaging with systemic neoadjuvant therapy or local regional therapy. Again, the setting for this is going to be incredibly selective, and it'll be analogous to what we do now for hilar cholangiocarcinoma, where we have to request individual patient exception requests. Importantly, I want to mention that there are a lot of contraindications for patients who would not be a good candidate for liver transplantation in this case. So patients with ICC recurrence, patients with evidence of tumor progression while waiting for transplant, whether that looks like increasing diameter, evidence of macrovascular invasion, new nodules, escalation of CA19-9, or extrahepatic spread. In our patient where the CA19-9, for example, has never been elevated, all of these things will be quite sensitive in detecting any changes in their clinical status. We wanted to also go back and talk about prior studies that have looked in this patient population, which show that in these patients with iCCA, they do quite well. These studies are more limited than the studies that we showed previously because they're retrospective, they're multi-center, and in a lot of cases, these patients were noted to have iCCA incidentally on explant. So these patients never received any neoadjuvant or targeted therapy, and prior to transplantation, there was no requirement for stable disease. Despite these limitations, and despite the fact that these patients were much sicker than our patient that we're talking about here, in instances with very early iCCA less than 2 centimeters, the 5-year survival was in excess of 65%. In patients with very advanced iCCA, whether lesions greater than 2 centimeters, or in many cases multifocal disease, the survival was near 50%. I want to emphasize again that in these cases, particularly with advanced iCCA, that the survival is an incredible underestimate because none of these patients received any downstaging therapy. And a lot of these cases were not known to have iCCA until explant. The second study demonstrates similar findings, and this is by DeMartin et al. And the main finding here is to note that in these patients, there are comparable survival rates in these patients with liver transplant who had lesions that were less than 2 centimeters, as well as those with well-differentiated iCCA between 2 and 3 centimeters. So the 5-year overall survival in these cases were 61% and 65% respectively. So going back to our framework, what we've demonstrated through both these prospective trials and these proof of concept trials is that liver transplant is likely to improve survival.
This is the timekeeper. Time has expired.
Thank you very much, Dr. Yu, for your presentation. Dr. Michelle Estrada from University of Cincinnati will now provide the con position. Michelle, when you get your slides up, you can begin.
Okay, thank you for inviting us to the debate. I'm one of the surgical fellows here along with Dr. Evans, and we also have Dr. Abadali. So the prompt is listed. Oh, can you guys see my screen?
Your slides are not up, Dr. Estrada.
Okay.
Now we see them.
Do you see it now? Yeah, okay. So thank you for inviting us. I'm one of the senior fellows on service or the surgery team here, as well as Dr. Evans and Dr. Abadali. So the prompt is that we have a stable unresectable intrahepatic cholangiocarcinoma, and that we think it should not be offered MELD exception points for transplant. We just want to clarify the case specifications on what we were arguing. Specifically, we were talking about non-incidental lesions, not mixed hepatocellular carcinoma lesions, and specifically lesions greater than 2 centimeters as related to the prompt. So we have 4 key arguments. So in general, just overall poor outcomes. Literature out there is, and we're going to quote much of the same literature, but many systematic reviews of what's been published in the past. Gupta in 2016 reviewed a case series that showed overall survival had a very wide range of 22 to 70%. And when matched with those patients who were transplanted for HCC, they had poorer outcomes. We use HCC as a comparison because this is a disease process that is provided with exception points. The other keynote was that there was a significant amount of extrahepatic recurrence in that group. Sapsochin in 2011 again showed that 5-year survival rates, as mentioned, was 47% in his group, and Robles is just one of the earlier case series, showed that there was 42%. And both of these survival outcomes compared to HCC is significantly lower. Those outcomes at these time points are usually about 70%. In discussing the recurrence rates, Sapsochin's group again reviewed and found that many of the main sources for death after transplant in his group was because of these recurrence rates, between 60 and 90% in his group, and extrahepatic. Robles found the same thing, as up to a recurrence rate of 35%. Looking at a study out of Wisconsin, when reviewing HCC, a large volume review there, their median time to recurrence rate was about 13 to 17 months on average, but their rates were very low at 6 to 16%. Overall, any recurrence of these disease processes after transplant have a lower prognosis, but I wanted to highlight that the recurrence rates for intrahepatic cholangiocarcinoma is significantly higher compared to the standard of HCC. Also, usually a disease process like HCC tends to have local regional recurrence, and there are additional therapies to treat that after transplantation that are listed below, with resection, TACE, Y90, and sorafenib, which is well studied. We also want to discuss that there is no real effective adjuvant systemic therapy that can have good outcomes here for biliary cancers. Current NCCN guidelines for unresectable disease is Gemcis or oxaliplatin, and we saw that there are studies that have showed no overall survival benefit. If you have an R1 resection with residual microscopic disease, we referenced the BILCAP trial, which showed it was a prospective randomized trial showing capecitabine versus no treatment, and they weren't able to meet their endpoint of showing overall survival. That study did show that there were some additional extended survival months of maybe up to a year, but in the setting of transplantation and using a scarce resources, we feel that is not an adequate amount of time added. Additionally, there's a lot of studies going on for gene studies and targeted immunotherapy. However, this in the setting of immunocompromised patients is difficult to assess. And finally, we argue that just overall, we don't have very strong data to level 1 data to support the outcomes of liver transplant either way, really, in these larger lesions. A lot of the studies that we've referenced are low-powered studies, case series, and retrospective. Just to summarize our point again, we are arguing that we should not allow for MELD exception points in stable intrahepatic disease for intrahepatic cholangiocarcinoma. And mainly, there's organ scarcity is involved here. We feel like there is a certain futility to it with having such high recurrence rates in cholangiocarcinoma with such poor prognosis. We do consider that transplant under research protocols with careful selection and standardized neoadjuvant approach for smaller lesions is an approach, but for larger lesions, we think the exception points should not be allowed.
Thank you, Dr. Estrada, for an excellent presentation. I'd like to now open it up to Dr. Aaron Hakim from Beth Israel Deaconess Medical Center, who will rebut the University of Cincinnati position. Aaron, you can begin.
Thank you, Dr. Taddy, for moderating this session. Thanks to our esteemed colleagues, and thanks to the American Liver Foundation for hosting this event. I want to start by emphasizing that we do not believe that liver transplantation is appropriate for all patients with intrahepatic hilar cholangiocarcinoma, but we believe that careful selection can lead to outcomes that exceed what we are currently achieving with transplant in oncology for hepatocellular carcinoma. I would highlight that many of the studies that our opponents cited from the 2016 era or previous were done in really patients who were unselected. They were merely found to have intrahepatic cholangiocarcinoma on explant. What we are proposing is selecting patients for favorable biology. So unlike those early studies with poor outcomes, what we propose is a neoadjuvant therapy requirement, similar to what we do right now in hilar cholangiocarcinoma, requiring a period of stable disease to demonstrate favorable biology characteristics of the tumor, requiring certain limits on size of tumor. Our patient has a 3-centimeter tumor, for example, and also perhaps putting parameters around differentiation, such as requiring moderately differentiated tumors. We think when we implement those criteria, and we look at the 2 most recent studies, such as the 2021 prospective study done by Macmillan et al., the 5-year overall survival rates are in excess of 60%. And we would highlight that those studies transplanted tumors that had a median diameter of around 10 centimeters. We would anticipate even superior results in our patient who has a 3-centimeter tumor. We would also compare this to the bar in HCC, where if we look at data from EASL in over 15,000 patients transplanted for HCC, the 5-year overall survival was about 60%, which we think we will exceed here. We are happy to require registries, to require submissions of protocols to UNOS, to require individual patient exemption requests, similar to what's done for hilar cholangiocarcinoma, and to ensure that this is done in the appropriate setting and that we can learn from the outcomes. But we think that the evidence exists to start doing this now. I want to talk a little bit about recurrences, because we believe that by favorable characteristics and favorable selection of patients, we can limit recurrences. But what I would also want to highlight is that the recurrence rate should not necessarily be something that we look at when we're trying to answer this question. We think that overall survival should really be the gold standard. And the reason is that recurrences may be slow growing, they may be addressable with resection, radiation, ablation, chemotherapy, or targeted therapy. We would highlight many new targeted therapies becoming available in cholangiocarcinoma, for example. And what we would argue for is a shifting in the mindset that in transplant oncology, we need to change our lens from cure to more prolonging survival. We think that in HCC, we've already done this because we know that transplanting patients who have been downstage has a higher post-transplant recurrence rate of HCC compared to patients who present within Milan criteria. And yet we are still transplanting these downstage patients. Ultimately, we believe that with careful selection, we can limit the recurrence rates, but that necessarily shouldn't be the only factor that we look at when considering transplant. The final thing that I would highlight is our opponents suggest that we wait for further studies to read out. We would highlight there are 3 studies looking at this question on clinicaltrials.gov. They will read out in the 2027 to 2035 timeframe and include 10 patients and 20 patients respectively. We think that the evidence exists to start doing this today instead of waiting another 10 years. And we think that, again, by creation of registries, by studying outcomes, we can learn to do better in this disease over time and really move the 5-year overall survival rate that's less than 5%. We think that prospective trials that Rosa quoted with 5-year overall survival rates in the 60 to 80% are an underestimate, and we are happy to propose this case.
Thank you so much, Dr. Hakim, for your rebuttal. I'm now going to turn it over to Dr. Sue Evans, who will rebut the Beth Israel Deaconess Medical Center position. Sue, you have the floor.
Good evening, everyone. Just to clarify, I'd like to just make it very clear that we're not debating whether patients ought to have access to transplant in this situation. Truthfully, these patients already do have access to transplant in certain situations. The point of the discussion tonight is whether the patients ought to be awarded exception points for transplant, meaning that they would have a higher MELD score and possibly easier access or earlier access to transplant rather than not having it as an option at all. And in the transplant world, those are vastly different situations. Given the paucity of high-powered data that both of the teams have actually talked about already, as well as long-term outcome information, stable, unresectable intrahepatic cholangio should not be an indication for MELD exception points for liver transplant. The proposition of being able to better select patients with an incredibly rare presentation of a particularly fatal form of cancer is an agreeable stance. But given that we don't currently have that data, and it's not appropriate to award exception points at this time without evidence behind it. Organ scarcity is a real problem, and we do need to have our due diligence done prior to implementing massive change in that system. Although tempting to make comparisons to HCC and colorectal cancer in order to further the case for transplantation in IHCC, there are significant differences between those entities and intrahepatic cholangiocarcinoma, and the position of the con side is that these differences act in support of our position. When compared to HCC, intrahepatic cholangio-related survival outcomes remain worse, and recurrence is more likely to occur extrahepatically. As previously stated, survival at 3 to 5 years is often under 50%, even in those with early or small IHCCs. A similar pattern exists in the case for colorectal mets, where recurrence of CRC in lung cancer or in the lungs occurs not infrequently, but that is actually amenable to resection, while the extrahepatic recurrence of IHCC is often not, and typically it is metastatic at the time of representation. Thus, the idea that recurrences are easily controlled is not true. Also, the relative almost curative intent of surgeries for patients with colorectal cancer following transplant is definitely not something that we often see in intrahepatic cholangiocarcinoma. Although encouraging, the 2014-2016 papers out of the Toronto group showing 50% 5-year overall survival involved very small tumors, but when larger studies were performed, the survival in small tumors was still high. However, larger tumors or multiple lesions still had low overall survivals. Although we've made progress to better understand the tumor characteristics of intrahepatic cholangiocarcinoma, further investigation into genomics and epigenetics, or broadly tumor biology, would allow for development of more targeted medical therapies, as well as to allow us to better predict the behavior of tumors and thus whether they would be responsive to treatments and be more or less likely to recur. That is not something that we're debating, however, because at this time, that is not the case, and thus should not be used as an indication to preemptively add exception points to those patients potentially undergoing transplant. As for other indications for liver failure, the option of living donor liver transplant exists. And as in the case of the Oslo protocol, development for the liver transplant for metastatic colorectal cancer in the SICA-1 and SICA-2 trials, this was used. And with further development of the selection policies in those cases, the survival of post-transplantation increased dramatically. One anticipates that further research into the investigation of IHCC in the same sort of form would be equally beneficial in that situation. There are other options as well with transplant, rather than giving exception points, which also include extended criteria donors and the use of living donor or partial grafts. So in conclusion, from the rebuttal side, although results of low power studies are encouraging for patients with small, often, at least in the literature, incidentally discovered intrahepatic cholangiocarcinoma following a stability period after neoadjuvant therapy is possible and on the horizon, and in some situations already ongoing, the use of transplant in the treatment of IHCC is not standard of care, even in some of the most common presentations of this disease. And as such, transplantation should remain a treatment option within the context of clinical trials or in these very selected patient populations, but it should not include the awarding of MELD exception points at this time based on a lack of.
This is the timekeeper. Time has expired.
Thank you, Dr. Evans, and thank you to both teams for getting the night off to a fantastic start. I'd like to begin the Q&A now, and I'd like to warmly welcome our judges, Drs. Keavney, Patel, Kapila, and both of our teams. So at this point, could all three judges turn their cameras on and all teammates turn their cameras on? And I'd like to open it to the judges and ask which of you would like to ask the first question.
So I'll start off. Excellent job by both the teams. I have a question for Dr. Yu or Dr. Hakim. This patient had a response to Y90. Do you think you could consider this response as a surrogate for how the tumor might behave biologically and warrant exception points?
Yeah, I think, thank you, Dr. Patel, for the question. We agree that the response to Y90 and the demonstration of stable disease on adjuvant chemotherapy is something that is likely to reflect favorable underlying tumor biology that will make it less likely to recur and as a consequence lead to favorable outcomes with transplant. I think that without awarding MELD exception points to these patients, they will ultimately never be eligible for transplant. And if we wait for their MELD to be high enough, they won't be able to tolerate the Y90 or the neoadjuvant chemotherapy to demonstrate stability of the tumor and favorable biology that leads to good transplant outcomes. So I agree with you. What this patient has demonstrated makes it more likely that he will be successful after transplant and exceed that sort of 60% bar that was established in HCC in the European registries at 5 years for survival.
Hey guys, great presentation from all sides. Really enjoyed that debate. So is there a size cutoff that you guys would propose? I know the 3 centimeter lesion was used in the vignette. But for the Beth Israel group, is there an upper size limit that you would use, similar to what we have with Milan? And for the group from Cincinnati, is there a lower size limit that you may consider, exception points in this case for?
Yeah, I think it's a really great question. And I think a lot of the prospective trials really demonstrated larger tumors. But because of what the Cincinnati team has mentioned about the scarcity of resources with livers, we want to be incredibly selective. We want to make sure that the patients that we do choose to offer exceptions to really will have prolonged 5-year overall survival. I think in that case, to start, at least in this initial stage, I think the 3 centimeter cutoff based on the study that we showed by DeMartin is really an appropriate one, so long as there's favorable tumor biology and there's stable disease on chemotherapy. As well, in terms of the lower bound, I think that really it depends on all the other factors that we mentioned, but we want to set our patients up for success and we want to make sure that the 5-year overall survival can exceed what's currently available. And right now, the 5-year overall survival is less than 5%.
From this group, we don't actually have necessarily a lower limit. I think the problem with creating size limitations at this point is that a lot of these tumors, or almost all of these tumors at presentation, are bigger than the 2 centimeters that all of the data is actually typically capturing. So the majority of the studies that are published have these small tumors that are incidentally found, or these very rare situations where patients present very early without any other signs of disease. And that is typically not the presentation, and it's hard to really show any evidence for anything other than what we know. In terms of the tumor biology, obviously that's very important. The use of neoadjuvant techniques and things like that are very helpful, obviously. But if you don't have a tissue diagnosis, oftentimes that's delayed. And in the case of intrahepatic cholangio, a lot of the times performing tissue biopsies, either through endoscopic means or liver biopsies, is actually not performed because of a presumed diagnosis and a fear of potential seeding. So I think those are definitely things that we have to look into prior to changing any kind of national guidelines. And as is the case for the Mayo protocol, when you're looking at perihilar cholangiocarcinoma, that requires a tissue biopsy, but oftentimes in this kind of cholangiocarcinoma, that's actually not performed at all prior to treatment.
Thank you very much again. Excellent job, the two teams. I have a question for the pro team, for Dr. Yu and Hakim. So in the two prospective studies you cited, the Lunsford and the Macmillan paper, can you comment on what the length of time was from time of listing to transplant, and whether that's relevant, given if you give a MELD exception score, you potentially shorten the waiting time?
Yeah, no, that's a good question, and obviously choosing the appropriate number of exception points to grant such that
I believe Dr. Hakim froze. So Dr. Yu, do you want to step in?
Sorry, he froze. I'm here. I'm Dr. Hakim now. So yeah, we were just looking in the studies that we cited, the prospective trials, a lot of these showed disease stability for at least 6 months on a given regimen. And so I think that that is an appropriate amount of time. And so to make sure that the favorable tumor biology persists, I think something important to mention, going back to what the prior team had said, was that a lot of these cases are biopsy proven. So we have a lot more information about how the tumor biology is behaving. And so from there, we can extrapolate about how these patients will do in that period of time where they're waiting for transplantation. I think that will allow us to really offer MELD exceptions to the most suitable patients. And this is going to be, again, a very selective patient population who's going to thrive after transplantation.
Let's open that question up to Cincinnati as well.
The waiting time.
I think we would say that we agree with about the 6-month mark, which is what we use for other forms of cancer that are undergoing transplantation due to liver metastasis, or in the case of HCC. However, I think that there isn't really any good consistent evidence for that. It's just something that's been worked into the protocols of multiple centers. And then as that has had good results in certain centers, that's adopted by other centers. And that kind of gets continued on without really, evidence to start that off at that marker. So I don't think from a tumor biology standpoint, we disagree. That would be great to have information about that. But I think the evidence is just lacking at this point in a lot of ways.
Thank you, both teams, and to our great judges for asking some fantastic questions. You can all take a nice deep breath now. You did a beautiful job. So we're going to now go on to our second team. So our second debate is whether or not structured weight loss programs should be required pre or post-transplant for all NASH patients, similar to alcohol-related liver disease. As a reminder, the pro presentation will be 8 minutes, followed by the con presentation of 8 minutes. So after that time, we'll welcome our rebutters, and then we'll have 5 minutes for Q&A. So the pro position will be represented by Yale University, and the con position will be represented by Emory University. So let's introduce these fantastic teams. Presenting the pro position that structured weight loss programs should be required pre or post liver transplant for all NASH patients, similar to alcohol-related liver disease. Their mentor is Dr. Albert Doe, and the fellows representing Yale University are Dr. Pravina Narayanan and Dr. Janine Zabak-Krill. Now, Emory University will take the con position that structured weight loss programs should not be required pre or post-transplant for all NASH patients similar to alcohol-related liver disease. Their mentor is Dr. Mary Flynn, and the fellows representing Emory University are Dr. Andrew Yu and Dr. Hima, sorry, I have this written down, Viramachanini, because I think it's very important to get names right. So Hima, I hope I did you proud tonight. All right. So as we prepare for debate number 2, Dr. Janine Zabak-Krill from Yale University will present her position. And Janine, once your slides are up, you may begin.
Great, thank you so much. All right. that all set? Okay, well, thank you so much. Thank you to the American Liver Foundation for organizing this event. On behalf of the Yale University team, I will be arguing the pro position for why structured weight loss programs should be required pre and post-transplant for NASH patients. There we go. So through the course of this presentation, we hope to convince you that participating in a structured weight loss program can benefit patients with NAFLD at all stages of their disease course and throughout the liver transplant process. Because obesity has negative clinical implications in the transplant setting, centers would benefit from implementing structured weight management programs. We can all agree that weight loss and maintenance of weight loss is difficult without guidance, even more so in the complex patient. As such, we aim to convey the numerous benefits to a structured weight loss program. We will conclude by highlighting the important parallels between NASH cirrhosis and alcohol-related cirrhosis with regards to structured relapse prevention. It is important to remember that weight loss is the only treatment for NAFLD. First and foremost, we want to prevent progression of liver disease at all stages. Weight loss from medical or surgical therapy can achieve this and can even prevent patients from requiring liver transplant. When patients do need liver transplant, we want to ensure that they are as optimized as possible, that we are able to increase access to timely transplant and minimize peri-transplant complications. Finally, we want to preserve and protect donated organs given their precious nature. Obesity is the most common and well-documented risk factor for NAFLD. The rising pace of obesity in the US predicts spikes in NAFLD and NASH to follow, with more than 50% in NASH-related waitlist additions by 2030. It is very unlikely that our access to organs will improve enough to ensure supply to meet this demand. Obesity is also common in patients with end-stage liver disease with etiologies other than NASH, and more obese patients are being listed for liver transplant. Obesity is associated with increased waitlist dropout and mortality, increased frailty and sarcopenia, increased risks of decompensation, portal vein thrombus, HCC, and cardiovascular events pre-transplant. Weight loss could mitigate these risks. Perioperatively, obesity is associated with longer hospital and ICU stays, infectious and biliary complications, and may be associated with increased morbidity and mortality. Structured weight management programs can help optimize patients for surgery and allow for pharmacologic or surgical treatment if necessary. Post-transplant, weight gain is a given. Metabolic syndrome is likely, and recurrent NAFLD occurs at an accelerated rate with worse cardiovascular outcomes. Being part of a structured weight loss program can help alleviate these risks by controlling metabolic parameters. This graph conveys the striking amount of weight gain in NASH patients post-transplant, almost immediately post-op, as compared to patients transplanted for other etiologies. Of course, there are various risk factors for post-transplant recurrent versus de novo NASH, including immunosuppression itself. However, obesity is a modifiable risk factor that can be diminished with the participation in a structured weight management program. The concept of a structured weight management program is not foreign, as evidenced by our existing guidelines that all advocate for supervised, structured, and multidisciplinary support for patients with obesity. Weight loss is hard. Even in the landmark prospective trial by Villar Gomez et al., with weight loss counseling alone, less than 10% of patients lost 10% of their body weight or more. Later studies have found more success with more structured and supervised programs. As such, patients need a structured weight management program to help them achieve their goals. We maintain that the priorities with any structured weight loss program should be safety and efficacy. The literature supports this. Promra et al. Showed that intensive lifestyle intervention groups lost significantly more weight than the control group who received standard weight loss education. The Sport Diet study looked at the benefits of an intensive 16-week lifestyle program and was able to prove that not only were these interventions safe, but that achievement of weight loss led to decrease in portal pressures. Centers such as the Mayo Clinic already have structured weight loss programs embedded into their liver transplant centers, particularly for patients with BMIs greater than 35. Transplant is already a multidisciplinary process that would create the foundation for a structured weight management program. BMI is an imperfect measure when it comes to patients with cirrhosis. Visceral fat and sarcopenia index measures are more useful and can be measured and monitored within a structured program. Close monitoring is essential because too much weight loss and the wrong type of weight loss can be detrimental, leading to frailty and sarcopenia. Structured programs also confer the ability for pharmacologic therapy to be utilized when indicated, as well as consideration of weight loss surgery when conservative measures fail. Structured programs can also be personalized to a given patient. Furthermore, a structured program can arm a patient with the tools to maintain and sustain weight loss. Such a program can also provide a long-term safety net for post-transplant patients to maintain healthy habits and allow them to remain engaged with the transplant team in an impactful way. We can learn a lot from alcohol-related liver disease and the parallels with NASH. Both disorders carry a stigma. Both are among the most common indications for transplant. Both are at high risk of relapse post-liver transplant, and as such, prevention of relapse is paramount. And both disorders would benefit from multidisciplinary and integrated relapse prevention programs. Rodriguez et al. And Adelorado et al. Both found that patients who received structured relapse prevention peri-transplant for alcohol had significantly lower rates of recidivism. Such successfully implemented alcohol relapse prevention programs set a precedent to be emulated for structured weight loss programs in maintaining and sustaining weight loss in NASH patients. Since weight loss is the only treatment for NAFLD, diet and exercise are the cornerstones for its management, especially in the context of transplant. Why would we not want to set our patients up for success with all of the tools that they need? Thank you.
Thank you, Dr. Zabak-Krill, for an excellent presentation. So we've now heard the pro position, and Dr. Andrew Yu from Emory University will now provide the con position. Andrew, when you share your slides, you may begin.
Good evening, all, and thank you for being here, and thank you for the Yale team for the opening argument. Him and I are here today to discuss the pitfalls of mandatory weight loss program in NASH cirrhosis and the reasons why this may not be feasible. Let's start by acknowledging that alcohol programs are not exactly a model structure. They have variable lengths and variable components, as well as differing milestones prior to listing.
Dr. Yu, are you intending to share slides? Because we don't see them.
Oh, sorry.
Don't worry. The timekeeper's got you covered.
That I did. Sorry, let's start from the beginning.
All right, you're in business.
Go. All right, so good evening, everyone, and thanks for having us tonight. And we applaud the Yale team for their excellent opening argument. As I was saying, alcohol programs are not a model structure. They have varying lengths and varying components, as well as varying milestones prior to listing. Moreover, there's a very high risk of recidivism following transplant, up to 40% in the first 5 years. Hardly the model program for a weight loss program. So what exactly is a weight loss program? What does it entail? They're also highly variable, but most of the time consists of a diet or exercise intervention with or without supervision. And there is a component of assessing physical activity as well as a target outcome. Presently, there isn't an established protocol for exercise programs in the cirrhotic population. Without a doubt, weight loss programs are beneficial in NAFLD. In this meta-analysis of 30 RCTs evaluating exercise and diet, there was significant benefit seen in weight loss, HOMA-IR, liver enzymes, as well as histology. There was significant heterogeneity between all these studies with duration, type of exercise, and diet. But the problem that arises time and time again is the durability of a weight loss program. In this study of a 24-week weight loss program, you see that there is benefit after 24 weeks in BMI, weight, blood pressure, and various metabolic indices. But when you look at 12 months after the program was discontinued, you see that nearly all indices return to baseline or surpass it. Why might that be? Well, this study aimed to evaluate barriers to physical activity in NAFLD and why compliance is so low. In this questionnaire, 91% of respondents agreed that activity was important in NAFLD, yet 75% did not achieve that 150-minute per week physical activity, citing various reasons, whether it was not enough time, resources, fatigue, or competing responsibilities. Now, there are clear benefits to exercise in cirrhosis, as the Yale team discussed with the sports study diet. This trial of 60 patients in a 16-week intensive program did show that there was benefit in weight loss as well as improvement in HVPG. But it is important to note that this study included mainly Child's A patients with an average MELD of 9 and excluded patients with decompensation and ischemic heart disease. Exercise is great. It improves sarcopenia, muscle health, fatigue, HVPG, quality of life. And it has been shown to be safe in compensated cirrhosis. But the data is still sparse. Studies are small. And these studies are mostly including patients with Child's A with an average MELD of 7 to 14. They exclude patients with other cardiopulmonary diseases. Thus, more studies are needed to evaluate exercise and weight loss programs in patients with decompensated cirrhosis or other issues with cirrhosis, such as hepatopulmonary syndrome or portal pulmonary syndrome that may limit their ability to exercise. Because the truth is, existing studies in weight loss programs do not represent our actual transplant population. This is the population that we're dealing with. Almost all have MELDs of over 15, over half with a MELD of over 25. How can you possibly mandate a weight loss program in a high-risk population where it has not been sufficiently studied in? What rates with higher rates of decompensation and other comorbidities? So ask yourselves, how feasible are weight loss programs in these populations? Many questions remain about implementation, especially given the absence of existing recommendations and protocols. With diet, what type of diet are you gonna implement? With exercise, how are you gonna get the patient who has overt hepatic encephalopathy, recurrent ascites out of bed? How are you gonna supervise these patients in the outpatient setting? And how are you gonna assess physical activity? Is it steps, a 6-minute walk test? And finally, how are you gonna measure the outcome? Are there certain milestones that you deem someone suitable for transplant? Do you remove someone off the wait list if they slip and skip a workout and gain some weight? This is clearly not a one-size-fits-all solution. And by doing so, you may deny patients or limit them from other alternative solutions on the horizon. In scenarios where a required weight loss program is not feasible, there are alternatives. One option is bariatric surgery. And I'm not arguing that one is better than the other, but these have been shown to reduce adverse liver outcomes and cardiovascular events in pre-transplant NAFLD patients, as well as provide durable weight loss in post-transplant NASH patients. Moreover, it is modeled to potentially be a more cost-effective alternative in patients with NAFLD, with improved life years gained and incremental cost effectiveness ratios when compared to intensive lifestyle intervention. In closing, while exercise and weight loss are paramount in the management of NASH cirrhosis, Mandating it for transplant is wrong. There is no data to show that it is beneficial across the board, and to mandate it does not make sense. We've shown that durability, compliance, and the feasibility remain in question. More data is needed in our sicker, higher MELD patients. The lack of this data underscores that in our patients with NASH cirrhosis, in our representative NASH cirrhotic population, that one size does not fit all. And by pigeonholing ourselves, we potentially deny patients alternative approaches that may potentially benefit them. Thank you.
Thank you, Dr. Yu, for an excellent presentation. We'll now move on to the rebuttal phase. So Dr. Pravina Narayanan from Yale University will now rebut the Emory University position. Pravina, you have the floor.
Thank you, Dr. Taddy, to the ALF for hosting this event, and to our colleagues at Emory for participating in this debate. I want to make one thing clear about our definition of structured weight loss programs before I proceed. We are not setting cutoffs for BMIs or imposing a minimal duration of participation prior to listing. We are simply providing the support and structure that is long overdue and long already advised to our patients with NASH undergoing transplant. Our opponents, in their failure to support structured weight programs for NASH patients, appear to be okay with the status quo, but we've heard from Dr. Zabak-Krill why they shouldn't be okay with this. We know NASH patients have higher risk before, during, and after transplant. They will die more from cardiovascular disease and malignancy. They will struggle more with malnutrition and sarcopenia before transplant. They will experience more weight gain, particularly in the first 6 months to 1 year after transplant, that will lead to metabolic syndrome and disease recurrence. If they need a retransplantation, they actually have lower survival at that time point compared to their non-NASH cohorts. Given all of this, we cannot be satisfied with the status quo in which we leave our patients on their own to contend with these complications, many of which are reversible, modifiable, and preventable with things like weight management. We even fail at providing the right advice. In a survey of liver transplant candidates and their caregivers, only 60% of them reported feeling that their clinicians even encouraged exercise. We heard from our colleagues at Emory that there's a lot of variability in these programs. We can actually learn a lot from alcohol-related liver disease in this sense during transplant. There's a novel new integrated program that's been published by our University of Michigan colleagues, published in 2021 by Winder et al. And in that, they support the use of an integrated program into the transplant center. And I think that's what would be best. We already have the multidisciplinary team to make that work. And the alcohol literature has already dealt with the fact that there are many different ways to provide substance use treatment. What they have found is that the structured supervised programs do much better than things like just offering CBT or other forms of behavioral therapy without a structured scenario. So our NASH patients deserve the same type of efficacious models that are already used for alcohol liver disease. At the end of the day, I did not hear in their presentation our opponents offer any alternatives that can be first line. Structured programs allow us to identify patients sooner who will benefit from the adjunct pharmacologic therapies that we know we're underutilizing in cirrhosis, and bariatric surgery, which does have very promising outcomes. But when you look at even those bariatric clinic studies, such as the Mayo Clinic study, where they published their initial cohort in 2013 and long-term outcomes in 2018, 36 of those patients, so 84% in the initial cohort, were able to reach a BMI under 35 with non-invasive multidisciplinary efforts alone. And 22% were able to maintain this weight loss 3 years after transplant. That's close to a quarter of patients that avoided an unnecessary and potentially harmful surgery and benefited from having a multidisciplinary team. We have the ability to empower our patients to lead more functional lives post-transplant. And we should want our patients to not only be alive after transplant, sure they have good outcomes from transplant with NASH, but we want them to thrive. And we need to shift our focus from short-term graft survival to patient-centered and meaningful clinical outcomes. This is exactly what structured weight loss programs have already been shown to provide. A study by Ingrid et al. In March 2021 showed that even a telehealth-driven 12-week program after transplant had improvements in metabolic syndrome severity score and quality of life metrics. In summary, we already have the multidisciplinary teams, the proof of concept models, and the technology to provide structured weight loss programs to NASH patients pre and post-transplant. It is in their best interests and ours to mandate and integrate their use. Thank you.
Thank you, Dr. Narayanan, for an excellent presentation. Again, in the rebuttal phase, we now will hear from Emory University. Dr. Vera Machinini will now rebut Yale University's position. Thank you.
You got
Hema.
it, Dr. Teddy.
All right, all right.
We appreciate the opportunity to debate tonight, and thank you for everybody for tuning in. Thank you also to Yale University for presenting the pro argument. So let's really talk about what it looks like to implement a structured weight loss program. So the plan would be to have these frail patients with high MELD scores and complications of cirrhosis like hepatic encephalopathy, which increases risk of falls, and ascites requiring paracentesis, and mandate that they go to an exercise program a certain number of times per week or per month. Would this be at the hospital or at home? What and how much do we expect them to do? For how long? How are we going to measure the success of the program? What is the endpoint or outcome? Is this sustainable? What if the patient has a fall while trying to exercise? Is this safe? Is the insurance company going to pay for this? Are we going to be punitive if they don't or can't adhere to the program? Would they get delisted like we do in alcohol-related liver disease? So as you can see, there are innumerable practical questions. This is precisely the problem with mandating a program for which we have no evidence or guidance on how to structure. With patients with varied ability to participate and without a clear implementation strategy or parameters outlined to measure success, we can't mandate something that simply doesn't have a framework yet. To address some of the points that the pro team mentioned, yes, physical exercise and lifestyle intervention are the first line of treatments for NASH and NAFLD. We totally agree with that. But I think most of the studies that they quoted, if we looked at them closer, you would see that the exercise improvement that was mentioned was in a cohort of compensated cirrhotics and MELD scores of 7 to 14. That is not the population that we're transplanting today. We can't simply apply the same thing to our patients with MELD scores of 30 that are awaiting transplant or being listed for transplant. Furthermore, they're decompensated with the complications and may not be able to participate in the things that these structured weight loss programs mandate them to do. Furthermore, less than 10% of patients even achieve the 7 to 10% weight loss recommended with lifestyle modifications at 1 year. And if they do, it's not durable weight loss. So what are we really achieving with this? Per the ASLD itself discussing exercise and cirrhotics, although supervised exercise training is a prevailing approach, such intervention is not sustainable or feasible for most patients. So we have to be realistic. And if we're talking about implementing a nutrition component to this, I think we have to be careful with recommending aggressive dieting to lose weight, because simply the important part of managing sarcopenia and frailty is ensuring adequate caloric intake and adequate protein intake. And aggressive weight loss could be hindering that and worsen sarcopenia and frailty, which are independent risk factors for mortality with transplant. My colleagues on the pro side also mentioned about the post-transplant outcomes with regards to weight loss and diet and exercise. It's important to note that the most important risk factor post-transplant is cardiovascular. And so in order to mitigate a cardiovascular risk, it's not simply diet and exercise that are the important components. We have to also address diabetes, hyperlipidemia, and take a comprehensive approach. Because even lean patients who undergo transplant for non-NASH related cirrhosis also have cardiovascular mortality post-transplant. It's important to note that this needs a comprehensive approach outside of just diet and exercise. And I think lastly, one point that was made was regarding NASH recurrence post-transplant. Kapuz et al. In 2017 looked at post-transplant survival for NASH-related cirrhosis, and it's comparable with those of other liver diseases. It's also important to note that despite NASH recurrence, it's been noted that survival at 5 years can be up to 90 to 100%. And so it's important to identify what the risk factors are that are actually leading to mortality, which has been shown by many studies, which is cardiovascular risk, and address those in a comprehensive manner. So the bottom line today is that this cannot be a one-size-fits-all approach, and to mandate something that is not clearly guided with parameters and repercussions would simply not be in the best interest of our patients. If the prompt today was we should encourage and advocate our patients peri-transplant to engage in exercise and nutritional eating, then we would not have a debate because we would agree with the pro team. But this is not the debate today. Instead, we are debating about whether we should mandate a program that we don't know is realistic or feasible, and we have no data supporting its durability or efficacy in our current high-risk MELD peri-transplant patients. And for all of those reasons, we cannot support this argument. Thank you.
Thank you, Dr. Vera Machinini, for an excellent presentation. So we now get to move into the Q&A session. I'd like to again welcome our judges, Drs. Keavney, Patel, and Kapila, and both teams. Please turn your cameras on and let's begin.
I would like to ask the con side. So the big question: should structured weight loss programs be required pre or post transplant for all NASH patients? Do you think a liver transplant program can mandate anything for a post transplant patient?
I think that's a good question. I think the data is still lacking in post-transplant patients for us to make that statement today. It is potentially more feasible, but I think again the question would be what post-transplant complications have occurred? Is it durable? And what are the outcomes from that post-transplant that we don't have enough data on at this point?
And I put the same question on the pro side. Can transplant programs effectively mandate patients do things post-transplant?
I believe so. You know, I think if we were debating a pharmacologic agent or a surgery, the need for a randomized controlled trial would be even more important. But we are already blindly recommending these to our patients, and we have the multidisciplinary team. We have the nutritionist, we have the physical therapist, we have the ability to get these metrics and follow up our patients. And so I think we have the tools already, and it's in their best interest. The mandate, I see it from my perspective, is for the transplant centers, not to put the onus on the patient, but to take it off of them, destigmatize having obesity and NASH, and give them the tools for success. So I think we can, and I think there's a lot of resources already that show how this can be done. The Mayo Clinic model, and a lot of work done by Dr. Punita Tandon at the University of Alberta to make these tools accessible even to the rural population.
Great. I have a two-part question. My first part will be to the pro side. What metrics do you propose following in a patient who is enrolled in a weight loss program? You know, BMI has its limitations. What metrics do you propose? And then I'll pose my second question to the con team after you guys answer this one.
Absolutely. So we thought a lot about this in preparation for the debate, didn't get a chance to say it all out loud, but so BMI has its limitations, even BMI adjusted after ascites. And one of the reasons we think the structure is so important is that the other measures, things like measuring visceral adiposity using a DEXA scan, and then all the frailty and sarcopenia measures, I think are super important here, because when we see a weight management program in the decompensated patient with cirrhosis, we see it more as optimization. We don't need them losing a ton of weight, but we need them increasing skeletal muscle mass and decreasing adipose tissue. So we need metrics that help identify that. And if they're doing, one or the other in the wrong way, then we need to catch that in the follow-up metrics. So we need a baseline testing of those things like 6-minute walk test, hand grip, things like visceral adipose tissue, and then be able to follow those up in the weeks of the structured program.
Great. And my question to the con team is, what do you do? You guys focus a lot on the high MELD patients who are in the hospital with an elevated MELD, who difficult to adhere to a weight loss prevention program. What about your ambulatory patients who come in maybe a MELD of 16, MELD of 20, or your patients with HCC who have a low biological MELD? How do you propose in those patients that there's no metric for following in terms of weight loss prevention? How would you approach those patients?
I think in those patients who are capable of exercising, this should certainly be enrolled in a weight loss program. What I mean to say is in the patients who are simply unable or too sick, there is no evidence that can demonstrate that this is a safe thing to do. It is going to be a case-by-case basis. So if you see someone in the clinic and they are healthy, they're more ambulatory, they seem like someone who does not have overt hepatic encephalopathy and has functionality, then it is appropriate to have them go through a weight loss program. But in the end, it all comes down to mandating across the board. You can't do this in everyone.
So I'll go next. That was a really excellent job by both teams. So thank you. I have a question for the Yale team. Yeah, not all patients with NASH are obese. So should structured weight loss be recommended for those non-obese patients in the pre-transplant setting?
I think the way we interpreted a weight loss program, a structured weight loss program, is having NASH patients have the ability to be formally evaluated by a multidisciplinary team to optimize all their metabolic parameters. So cholesterol, A1C, things like that, and visceral fat mass. Just because patients are lean doesn't mean that they don't have, visceral adiposity that they can lose and optimize. I think one follow-up to that is there's a lot of emerging literature of just how harmful being sedentary in the waitlist setting is, low step count, all of those things. And so I think that's just as applicable to the patient with low NASH. And I think we can extrapolate. These are programs that probably everyone will benefit from in the peri-transplant setting, but we were specifically asked to comment on the NASH population.
Thank you.
Does the Emory team want to take that question as well?
Sure. To address kind of like the healthier patients that are able to exercise, I think that at the end of the day, a lot of these structured weight loss programs haven't shown durability, which is what I find as the biggest negative side to them. With regards to lean patients with NAFLD, I agree with the fact that we have to address what their current status is and metrics and things like that. But the problem is that there's not a framework in place for that. So I think that's where we're not there yet. And at the end of the day, the sarcopenia, the frailty, and the other components that are associated with cirrhosis can also happen in lean patients. So I think we just need some more data and framework before we consider implementing it across the board.
I want to thank our judges for outstanding questions and our two fantastic teams, Yale and Emory. Take a deep breath. You did a fantastic job. You built on the momentum set by Beth, Israel, and Cincinnati, so we're having a fantastic night. I'd like to go ahead and introduce the third debate. So the key clinical question for this debate is who should get preference for liver transplant? Very tough question. The case associated with this topic features a NASH patient who has been unsuccessful in losing weight versus a patient with alcohol-associated liver disease with documented 6 months sobriety. Both patients are 45 years old with a MELD sodium of 25. Both patients have ascites on moderate dosages of diuretics and non-bleeding esophageal varices. The NASH patient has a BMI of 40, type 2 diabetes on insulin, a hemoglobin A1C of 8%, and has struggled with obesity since his late teens. He has a supportive family and does not drink alcohol. The patient with alcohol-associated liver disease has a BMI of 25, no other medical problems. He completed an intensive outpatient program 3 months ago, has a supportive family, and is felt to have very good insight into his alcoholism, both by social work and psychiatry. As a reminder, the pro presentation will be 8 minutes, followed by the con presentation of 8 minutes. Next, we'll welcome each of our rebutters separately. They'll have 5 minutes apiece, and followed by question and answer. So let's introduce our teams. Arguing for the pro position is Rush University. Arguing for the con position is Ascension Providence Hospital. So let's talk about these fantastic teams. Presenting the position that the NASH patient should receive preference is Rush University. Their mentor is Dr. Sujit Janardhan. The debaters representing Rush University are Dr. Richard Manfredi and Dr. Allison Sipsinski. So the con will be argued by Ascension Providence Hospital. They're basically arguing that the ALD patient should receive preference. I guess we can't really call it a con. It's sort of, I guess, the other preference. Their mentor is Dr. Mark Piper, and the debaters representing the Ascension Providence Hospital are Dr. Lina Allneimer and Dr. Arij Mazar. So let's begin. Dr. Richard Manfredi from Rush University will now present their position. Richard, when your slides are up, you have the floor.
Okay, great. Hopefully you can see my slides. All right. Good evening, colleagues, friends, and judges. Thank you for joining us as we explore an interesting and thought-provoking topic within our field. I'm Rich Manfredi, a fellow at Rush University. The question at hand tonight is whether a patient with NASH cirrhosis who has struggled with obesity should receive preference for liver transplantation over someone with alcohol-associated liver disease. My colleague, Allison Rebsinski, and I are going to make it abundantly clear to you that preference should go to the patient with NASH. Today, NASH is the fastest growing indication for liver transplantation listing, according to recent UNOS data. You can see that NASH as an indication for listing has grown exponentially relative to levels in 2002, including patients both with and without HCC. NASH has far outpaced alcoholic liver disease when we compare rates of growth. And in the very near future, NASH will be the #1 indication for liver transplant. It already is #1 for certain subpopulations. It would therefore be inappropriate for us to have any hesitancy in transplanting this patient population. Now, we do recognize that in the current day, alcohol remains a highly prevalent indication for liver transplant. But the critical difference between patients on the wait list for NASH and those waitlisted for alcohol is that patients with NASH are far more likely to die while waiting. Compared to alcohol, NASH patients are far more likely to die on the waitlist, according to a 2021 study of waitlist mortality. This means that our patient will die faster on the waitlist than the ALD patient who has the same MELD score. And given the prevalence of NASH, we are talking about a large number of impending waitlist deaths. And as if that were not enough, you can see on the figure on the right that ALD patients are much more likely to recover on the waitlist, whereas patients with NASH are simply more likely to die. Now, you may be wondering how NASH patients fare after liver transplant compared to patients with other liver diseases. Well, in the largest meta-analysis of 9 studies, examining over 4,200 patients undergoing liver transplant, there was no difference in survival at 1, 3, and 5 years for patients transplanted for NASH versus for other indications. These findings have been confirmed in several other more recent studies. Now let's compare directly to ALD. In a 10-year retrospective look at post-transplant outcomes at the University of Miami, there was no statistically significant difference between NASH and ALD survival at 1, 3, 5, and 9 years. This was followed up by a 2019 prospective review of post-transplant outcomes in Spain that you can see here, which confirmed there was no significant difference in survival between NASH and alcoholic cirrhosis. So we've seen that patients with NASH do worse pre-transplant than patients with ALD, are less likely to recover, and have similar post-transplant outcomes. But you may wonder whether the coexistence of obesity can ruin these outcomes. Well, now, while this is a commonly held theory, in reality, it is purely a stigma based on old data. A 2008 study found that pre-transplant BMI is not an independent predictor of either patient or graft survival. This effect was redemonstrated in 2013 using more than 1,300 patients in the UK, and then again in 2016 using 80,000 patients on the UNOS registry. This last study, which is shown on the right, demonstrated that increasing BMI is associated with increasing waitlist mortality, but it does not influence post-transplant mortality. So this illustrates essentially that the greater the BMI, the greater the survival benefit conferred by liver transplant. Now, you may think that the inability of our patient with NASH to lose weight and the ability of the patient with alcoholic liver disease to achieve sobriety is a sign that our patient may be less compliant. However, there are several reasons why this comparison is unfair. We recognize that achieving sobriety in alcohol use disorder is not easy. However, the patient with ALD has multiple opportunities to achieve behavioral changes, while the NASH patient faces nothing but barriers. For example, the ALD patient has available several well-established outpatient resources to help achieve sobriety. However, in decompensated NASH, there are no validated weight loss programs or medications. As our colleagues at Emory pointed out expertly, this is a major issue. We know this because we are one of the few centers that focuses on healthy weight loss interventions in patients with decompensated NASH. Insurance will pay for multiple modalities to help achieve sobriety. However, they will not pay for weight loss programs, which can be very expensive. Furthermore, patients with NASH face several physiologic barriers, such as sleep deprivation and sarcopenia, that make weight loss extremely difficult. So we know that obesity does not affect survival and that weight loss is challenging, but is there any benefit at all to our patient losing weight before surgery? In a large study of 38,000 transplanted patients on the scientific registry, there was no survival benefit with weight loss. Specifically, the authors analyzed BMI change on the wait list and found there is no survival benefit for a patient with a BMI of 45 who loses weight compared to a patient with a BMI of 45 who does not lose weight. This leads to our next point, which is that weight loss would in fact be detrimental. Weight loss, even in healthy patients, is known to cause loss of skeletal muscle mass. Our patient with NASH cirrhosis is already in a catabolic state with sarcopenic obesity. So asking him to lose weight would exacerbate the sarcopenia. And in numerous studies, preoperative sarcopenia is clearly associated with decreased patient survival and graft failure. And it is also a predictor of increased infections, kidney failure, and length of hospital stay. So in conclusion, it is absolutely critical that we recognize NASH as the fastest growing indication for liver transplantation. On the wait list, these patients are more likely to die and less likely to recover than patients with alcohol-associated liver disease. There is no difference in post-transplant survival for patients with NASH versus patients with alcoholic liver disease. And contrary to the stigma, survival is not affected by high BMI. And in fact, it is this high BMI population that derives the greatest survival benefit. Finally, the behavioral intervention of weight loss asked of the NASH patients is unrealistic, does not improve survival, and may in fact worsen outcomes. So when comparing these two patients, our patient with NASH is more likely to die waiting for a transplant, but has identical survival post-transplant. And it is for this reason that we believe there is every reason to prioritize our patient with NASH and no reason not to. Thank you very much to the Rush Transplant Hepatology team, Dr. Janardhan, Dr. Biglin, and the rest of our colleagues.
Thank you, Dr. Manfredi, for an exceptional argument. So I'm now going to turn it over to Dr. Lina Alnheimer from Ascension Providence Hospital, who will provide the con position. Dr. Alnheimer, once you share your slides, you've got the floor.
Hello, everyone, and thank you for joining us tonight. My name is Lana Alnheimer. I'm a third-year medical resident at Ascension Providence Hospital. I would like to thank the American Liver Foundation for this great opportunity. In the next 8 minutes, I'm going to tell you why the patients with alcohol-associated liver disease should take preference in liver transplant. A quick recap of the case study. As you can see here, both patients share similar age, gender, MELD sodium score, and decompensations of cirrhosis. However, there are some key differences that we need to point out. The NASH patient has a BMI of 40, the ALD patient has a BMI of 20, and the medical conditions associated with the NASH patient include type 2 diabetes with an A1C of 8%, on insulin therapy, and obesity, while the ALD patient has none of those medical problems. In addition to that, the NASH patient has been struggling with obesity since late teens and continues to do so, while the ALD patient attended an intensive outpatient program, has documented 6 months of sobriety, and has good insight into his alcohol use disorder, documented by both social work and psychiatry. In this presentation, I'm going to go over the definition of ALD, the burden of disease, the arguments supporting the preference for ALD patients, and the conclusion. Regarding the natural history of ALD, as you can see in this image, it involves a variety of clinical disorders, starting with steatosis that can progress into steatohepatitis, fibrosis, and eventually into alcoholic-related cirrhosis, which can be complicated by hepatocellular carcinoma, but in a higher percentage of patients by decompensated cirrhosis or acute on chronic liver failure, like our patients. Regarding the burden of alcoholic-associated liver disease, I'm going to discuss the epidemiology of it, the costs associated with it, and the impact of the COVID-19 pandemic on it. Starting with the epidemiology of ALD. As you see in this pie chart, ALD makes up to 18% of etiologies of liver transplant in the US, just second to hepatitis C virus. But it's not only the second most common cause of liver transplant. The mortality has been high and continues to increase over the years. As you can see, the significant jump between 2019 and 2020. When we compare mortality, it's not only that ALD has been high and continues to increase, but NAFLD numbers seem to be somewhat stable or decreasing, and the difference between both of them is becoming greater. Moving on, let's discuss the costs associated with alcoholic-associated liver disease. Costs are higher in ALD, as you can see in this figure marked by the red boxes. Not only that it's similar to incidence and mortality, which are also high in ALD, but the costs are higher as well compared to the NAFLD costs, as healthcare costs, which somewhat have been stable or decreasing over the years. How about the impact of the COVID-19 pandemic on ALD? As you can see in this graph marked by the red arrow, by the red line, ALD in the COVID era has been far more than non-ALD and ALD in the pre-COVID era. Since the start of the COVID-19 pandemic, ALD has become the most common indication for liver transplant and accounts for more listings than HCV and NASH combined. So those differences between ALD and NAFLD have been heightened by the pandemic. After I've shown you how burdensome ALD is, I'm going to move on and discuss the arguments supporting ALD preference. Argument number one, differences in relapse between our ALD patient versus their NASH patient. There's a risk of relapse in any etiology of liver disease after transplant, and the risk of relapse in our patient is particularly low. When researchers looked at the risk factors for relapse after transplant, they found out that abstinence for more than 6 months and the absence of psychiatric disease is actually associated with better outcomes. Not only that, but the risk of NAFLD recurrence is actually high. And one of the main risk factors for that is insulin-dependent diabetes, which the NASH patient has, as you can see in this study. Argument number two are the differences in post-liver transplant survival between our ALD patient versus their NASH patient. So hypothetically speaking, let's say that both patients share similar baseline characteristics such as BMI and other medical conditions, then the etiology of liver transplant wouldn't really matter in terms of survival, and non-ALD versus ALD would be the same survival. However, in reality, they're not, and one of the predictors for worse LT outcomes includes diabetes, as you can see in this study. Both overall survival and graft loss were associated with worse outcomes. How about if you couple obesity to diabetes? That actually predicts worse 5-year outcomes, as you can see in this study as well, marked by the red arrow over here, versus patients who do not have obesity or diabetes have much higher survival. How about BMI greater than or equal to 40? It's actually an independent risk factor and it predicts worse outcomes, as you can see in this study. It's not only about survival, but ICU stay has been higher. The length of stay in days has been higher. The requirement for blood transfusion, the return to the operating room, and the readmit rate compared to someone who has a BMI of less than or equal to 30, such as our patient with a BMI of 25. BMI greater than or equal to 40 was also associated with worse survival, as you can see in this study, both on univariate and multivariate analysis. And this study was done in 30,000 patients during this period of time. My last argument for tonight is the differences in pre-liver transplant interventions between our ALD patient versus their NASH patient. So their NASH patient, on his journey to cirrhosis for more than 30 years, he did have some options for medications, such as GLP-1 analogs, which have shown NASH resolution in some studies. 10% weight loss also helps with that and has proven to show NASH resolution. And bariatric surgery, including both Roux-en-Y bypass and sleeve gastrectomy, also helps in NASH resolution. Our patient has done everything possible, including abstinence and treating his underlying addiction. And there are no other medications or surgical options for an ALD patient. So what do our practice guidelines have to say about this? Both AASLD and EASL agree that liver transplant for ALD patients is an excellent indication. In addition to that, candidate selection for liver transplantation in alcohol-associated cirrhosis should not be based solely on a fixed interval of abstinence. To close, we as healthcare providers, we need to understand that ALD patients are not less deserving than all other patients, and we need to strive to reduce the stigmata around this disease. ALD is actually an excellent indication for liver transplant for all the reasons that I've shown you. We do agree that patient selection after comprehensive psychosocial evaluation is key. Our ALD patients should take preference in this case because compared to their NASH patients, their risk of relapse is lower, the post-liver transplant survival is better, and he has met every single requirement to improve the chances of success. However, giving a new liver to the NASH patient is not going to cure the metabolic syndrome that he seems to have. Thank you.
Thank you, Dr. Alnemer, for an outstanding presentation. I think Rush and Ascension came ready to rumble tonight. So we are going to hear the rebuttal. Allison Rupczynski from Rush will now rebut Ascension Providence Hospital. Allison, you have the floor.
Thank you to our Ascension colleagues for providing that counter argument. However, as Richard explained, we believe our NASH patient should be prioritized for transplant over the alcoholic liver disease patient for the simple fact that there are all the reasons to prioritize our NASH patient and no reason not to. Our current liver allocation system using MELD and MELD exception points prioritizes the patients with the highest pre-transplant and waitlist mortality. This means we prioritize the patients that are most likely to die. The evidence clearly shows that NASH patients are more likely to die while on the waitlist. And I want to highlight that this is talking about patients on the waitlist and not just looking at in-hospital mortality or general mortality. In contrast, alcoholic liver disease patients are more likely to recover. Due to this critical difference, it is abundantly clear that we should be prioritizing the NASH patient population over the alcoholic liver disease population. It is important to reiterate that there is no difference in survival after liver transplant between patients with NASH cirrhosis and patients with any other end-stage liver disease, including alcoholic liver disease. The information that our Ascension colleagues presented is old data, and the newer data from 2007 has clearly shown that there is no difference in survival. This remains true even for patients with morbid obesity and BMIs greater than 40. In fact, it is these patients with the highest BMI that derive the greatest survival benefit from liver transplant. At the end of the day, we want to provide these precious life-saving organs to the patients that will gain the most survival benefit. It is clear that this is our obese NASH patient. Ascension has brought up the fact that obese patients can sometimes have increased intraoperative complications. While this may be true, it is important to remember that these complications have no impact on survival. Furthermore, NASH as an indication for waitlisting has exponentially increased since 2002 and is far outpacing the proportion of patients that are waitlisted for alcoholic liver disease. It is therefore vital that we continue to improve and optimize our technical expertise in transplanting obese patients. It is unfair to compare alcohol abstinence and weight loss as equal requirements for liver transplant. The path to weight loss for a patient with decompensated NASH cirrhosis is littered with structural, financial, and physiological barriers. Therefore, it is crucial that we do not mistake the inability to lose weight for a lack of compliance. More importantly, why should we require weight loss prior to transplant when this portends no survival benefit and may in fact be dangerous for our patient? This is in stark contrast to alcohol abstinence, which can only benefit a patient with alcoholic liver disease and may even lead to ongoing recovery without the need for transplant. We recognize that there are increased cardiovascular events in the post-transplant NASH population. That being said, these cardiovascular events have no impact on overall mortality, which should be our main focus when considering transplant. It is well known that patients with decompensated NASH cirrhosis do not receive adequate optimization of their metabolic comorbidities. With simple medical management, we still have the opportunity to modify these metabolic risk factors pre and post-transplant to prevent cardiovascular events. What's more, according to Baggett et al., the relative risk of an alcoholic liver disease patient dying of malignancy was higher than that of a NASH patient dying of cardiovascular events post-transplant. In contrast to our NASH patient, there is no simple medical management that can prevent alcoholic liver disease patients from dying from cancer. And yet this does not seem to matter to our Ascension colleagues. Additionally, the metabolic factors that increase post-transplant cardiovascular events in our NASH patients can be mitigated by performing a simple 30-minute procedure at the time of transplant. When sleeve gastrectomy was combined with liver transplant in obese patients who were unsuccessful with pre-transplant weight loss, there was a higher resolution of diabetes, lower BMI, and fewer post-transplant metabolic complications at follow-up with durable effects through 3 years, who were enrolled, and this was compared to NASH patients who were only enrolled in a weight loss program pre-transplant. Based on this data, it would actually be more beneficial for a patient to undergo a sleeve gastrectomy at transplant than would be for them to lose weight prior to transplant. Lastly, Ascension has raised the issue of recurrent NASH as a reason not to transplant our patient. O'Neill found that patients with alcoholic liver disease gain more weight than NASH patients post-transplant, implying that these patients also have a risk for de novo NASH. Moreover, despite the presence of recurrent NASH, retransplant rates and graft loss are no higher for NASH patients as compared to alcoholic liver disease patients. Ultimately, our NASH patient will die if they are not transplanted, as the waitlist mortality for the NASH population exceeds that of alcohol-related liver disease. If there is no difference in survival, then why would we not transplant the group that would gain the most benefit? We believe it is abundantly clear that there are all the reasons to prioritize our NASH patient and no reason not to. Thank you.
Thank you, Dr. Ripczynski, for a wonderful rebuttal. All right, now we'll turn it to Dr. Arij Mazar from Ascension Providence to rebut Rush University's position. Arij, the floor is yours.
I'd like to thank the American Liver Foundation for giving us this opportunity to participate. And I'm again going to tell you why our ALD patient deserves a liver transplant over the NASH cirrhosis patient. First of all, it's important to understand that alcohol is an addiction, just like leading an unhealthy lifestyle is an addiction in NAFLD. You're basically trading one addiction for another. Not only is that important, but we also have to realize that these ALD patients are often stigmatized against, which already puts them at a disadvantage. They're from a lower socioeconomic status, they're discriminated against, and we as clinicians also contribute to that disadvantage because we're not very good at providing resources to assist them with cessation of alcohol addiction or prevention of relapse. Secondly, ALD has a very high short-term mortality, up to 50% in 3 months in some studies. These patients simply don't have the time or the liberty to wait 6 months to qualify for a liver transplant, which in contrast to the NAFLD patient that our Rush colleagues are supporting, that's a more slowly progressive disease. That patient has had so many missed opportunities, so many chances to improve their disease before they got to this point. He's been struggling since his teens. His A1C is 8. He can't even be compliant with his diabetes medications or even be compliant with a diet or weight loss program. Why does he deserve a liver transplant over our patient? And second of all, as my co-fellow mentioned, these NASH patients have other opportunities: weight loss, dietary changes, GLP-1 inhibitors, pioglitazone, even bariatric surgery. And what does the ALD patient have? We don't have bariatric surgery. We don't have these medications. Oh, steroids? Yeah, you can use them in certain patients who have alcoholic hepatitis, but not even all of them qualify for steroids. There's so many contraindications for that. And when you give those steroids, that's based on short-term mortality scores. It doesn't affect their long-term mortality. And furthermore, steroids also increase that risk of infection, themselves. And thirdly, going back to this 6-month abstinence rule, that number is so arbitrary. Who came up with this magic 6-month number, and why do we follow that? That's been challenged multiple times, most famously in a study by Mathurin and colleagues in 2011, basically showing that patients with even less than 6 months of sobriety had good outcomes. And there's even studies out of Asia of living donor liver transplants who had 3 months of abstinence who had 80% 1-year survival post-liver transplant. And when you look at actually the 6-month rule, it doesn't even correlate well with the rates of relapse or graft loss or retransplant. And fourthly, let's talk about relapse. Nobody talks about, relapse in NAFLD and NASH cirrhosis. Everyone loves to talk about relapse in ALD. If you actually look at those ALD studies, the definition of relapse is different within the same study. Is it a slip? Is it heavy drinking? How are they measuring it? Is it self-reported? Is it these non-sensitive, blood alcohol tests or urine alcohol tests? Who knows? But what about these NAFLD and NASH patients? You're giving a transplant to this NAFLD patient. It's not going to fix their metabolic syndrome, their diabetes, their obesity, hyperlipidemia, hypertension. It's like putting a Band-Aid on that. And actually putting them on immunosuppression can make their diabetes worse, can cause even further fatty deposition in the new liver, and then this cycle repeats again. Fifth of all, if you argue that liver donation is a scarce resource, I don't think so anymore, especially with the living donor liver transplants now being the solution to that problem. And finally, we don't withhold life-saving treatments from other patients who we say have so-called self-inflicted harm. So for example, we don't say like an ALF Tylenol overdose patient doesn't deserve a liver transplant, or a car accident victim who didn't wear a seatbelt, or a motorcycle accident victim who didn't wear a helmet, or a smoker who needs a cabbage or needs cancer treatment. We don't say, oh, haha, yeah, you did this to yourself, so you can just die and you don't deserve treatment. We don't do that to those patients, so why should we do that to our ALD patient? It's actually really sad that most ALD patients actually don't have access to liver transplant programs, and this was demonstrated in a 2018 study by Chang and colleagues, basically showing that 100,000 patients a year in 2018 with ALD qualified for liver transplant, but only 10% were referred, which equates to a 1.2% of those transplants that year being ALD patients. And that also equated to as many as 12,000 deaths per year of this patient population. And that doesn't even account for, by the way, patients who died on the wait list and patients who were never ever actually referred for a liver transplant. We don't even know what that number is. So, with all these points I mentioned, I don't think I have to convince you further that our ALD patient deserves a liver transplant. He has good insight into his disease. He has good social support. He has been sober for 6 months, and he also did a 3-month abstinence program, rehab program. So our patient with ALD deserves this liver transplant, and it would be unethical to withhold it from him. Thank you.
Thank you, Dr. Mazar, for a wonderful rebuttal. All right, let's ask our esteemed judges to come back on camera. Doctors Keavney, Patel, and Kapila, and both teams to come on camera. Who'd like to ask the first question?
I'll start off. So, those are outstanding arguments from both of the teams, so thank you for that. My question is, should comorbidities such as, let's say, diabetes or a BMI of 40, should you be including those formally in our prioritization scores for liver donor allocation?
Was that directed to our team?
To both teams.
Okay. So we can sort of answer that. So yes, everything our colleague said about diabetes and cardiovascular risk is true for patients with NASH. However, none of it has a bearing on actual survival, which at the end of the day is what we really care about the most. The other question is whether or not improvement in diabetes or loss of weight should have any bearing on the outcome as well. And that's just not the case. Essentially, we're the number one indication for liver transplant is also the number one reason why for recovery, and that's alcohol. So in fact, NASH patients are being underrepresented, and it's not because of diabetes or because of obesity. It's purely because they are not being listed as much as they should. So I don't believe that necessarily we should incorporate diabetes or obesity into the guidelines. I just think that when we look at survival, which is the ultimate outcome, there's no difference.
And furthermore, to that effect, there has been studies that have shown that sometimes NASH patients are unfairly not listed simply because people are afraid to do surgery on these patients. But looking at all the data, the patients with a BMI still above 40 have still had the same survival. And ultimately, even though there might be some more intraoperative complications, that hasn't affected the overall survival. So I think, as we alluded to before, I think that now that NASH is growing in the population, we all know that it's not going anywhere. We need to just start honing in on our technical skills and not being hesitant to transplant this population. So I think putting any further requirements on it or or like restrictions is only going to harm this population even more when they're surviving just as well as all of our other end-stage liver disease patients.
So actually, we disagree with that, and we think that diabetes and other metabolic syndrome factors, as well as BMI, should be included. Alcoholic liver disease, it's more than just alcohol, it's a disease. Same with NAFLD or NASH, it's also psychological. And that part is not addressed, when you're saying like, yeah, okay, we're going to transplant you with a BMI of 40 with uncontrolled diabetes, when you're not taking care of the underlying problem. You're not helping them with their metabolic syndrome. And if you transplant them, if they're not even compliant with their diabetes medications, they can't even, be compliant with a weight loss or dietary program, which got them here in the first place. How are they going to be compliant with their immunosuppression? And furthermore, the immunosuppression itself can cause them to get fatty liver again. And it just feeds into this vicious cycle because you never fixed the underlying problem in the first place. And you didn't address like the psychosocial factors that go into obesity either. So I think it's important to include it and not to discriminate patients based on their BMI or their metabolic factors, but to actually come up with a program to help them, achieve that weight loss and the BMI. We're not saying that these patients should become sarcopenic, obviously. We're just saying that for their own better outcomes, for control of their diabetes, that we can provide them with resources to help control all of those metabolic conditions and for them to have a better outcome post-transplant, and also perioperatively with less infections because of their uncontrolled diabetes and other complications associated with high BMIs as well. And actually a lot of, I don't know if it's a lot of transplant programs, I don't know what the actual number is, but some transplant programs actually don't transplant patients with a BMI above 35.
I just want to say one more thing. We're talking a lot about saying that our patient is non-compliant, which is a stigma that's saying because he hasn't had weight loss right now that he is not compliant. We have no idea how he's been compliant with his insulin. I think that's an assumption that Ascension is kind of making right now and trying to portray our patient saying that he's not doing anything to help himself. And again, as Rich has talked about, the path to weight loss for our patient, it is full of barriers. There is no standardized type of weight loss programs out there. We do have great programs for alcoholic liver disease patients. And I'm not saying that one is easier or harder than the other, but the difference is that there are standardized alcohol rehab prevention programs. We have medications that help with alcohol addiction, but we do not have those same things for obesity. And additionally, talking about losing weight, I mean, without having a structured weight loss program, these patients are at risk for sarcopenic obesity. For every 10 pounds that a patient loses, they also lose 2.5 pounds of muscle. So someone who already has sarcopenic obesity is just going to lose even more muscle with every every pound that they lose. So I think that kind of harping on our patient as being non-compliant is a little just making an assumption here.
So the reason we're saying that is because, in the prompt, it says that the patient, since he was a teenager, has been struggling with his diabetes and has not been successful at losing weight. So
has 40% of our American population, unfortunately.
Arguing that, and yes, we know that there is no standardized program that exists. We're not saying that you should exclude them. We actually said that there should be a standardized program developed to help these patients. Actually,
but there's not right now, so that's the difference.
There should be.
Wow, one question. That was a great question, Dr. Patel. All right, so we are at time for question and answer, and we've had a very hot end of the night. So we're going to give the judges some time to deliberate. And as we sort of wrap up the evening, I'd like to really express our gratitude to our generous sponsors for their support of the academic debates, national premier supporter sponsors, AbbVie and Eisai. So we really want to thank everyone for their efforts tonight. And we understand how high pressure debates can be, but wow, what poise and what brilliance we saw tonight. Everyone who's been involved with the academic debates knows that this is quite a feat to pull off, let alone in a whole week of March Madness. And as a gentle reminder, there's still time to donate so that the American Liver Foundation can continue its important work. We are very close to reaching our goals, but we need some more donations to really hit the finish line and hopefully to exceed that finish line. You'll find a link to make your donation in the Q&A box. So please click on that link in the Q&A box. No donation is too small or too large. While you're making your donation and we begin making closing comments, all of our mentors and debaters will join us for the final comments of the evening. I'd like to congratulate all our teams on an outstanding job and to thank their mentors for their expert guidance, our judges for their thoughtful questions, and the ALF tech team who really pulled it off tonight and every night this week, and to all of you for joining us this evening. So as a reminder, Debate Madness will continue tomorrow night. So please register for this important virtual program and help us promote them to the healthcare community. Please remember to visit the ALF website and recommend it to your friends, families, colleagues, and patients. As a reminder, ALF has many resources for patients and caregivers, and we offer exceptional educational programs to our healthcare professionals. We encourage you to visit the links on this slide to explore all that we have to offer, and please encourage your patients to visit us too, and our helpline. Liver Life Walk is a signature event of the American Liver Foundation. It allows people affected by liver disease to come together to raise awareness and funds. It also gives them the opportunity to support each other in a festive and inspiring environment. We're happy to announce that in 2022, we're planning to host 13 in-person walks across the country, as well as a virtual walk. Visit liverlifewalk.org for more information. And you might be interested to know that back in 2005, when I was a second-year fellow, that's how I got involved in the Liver Life Walk. I went to my first walk and was just blown away by the overwhelming sort of support between patient and provider. There's nothing like putting on your sneakers and walking with your patients. The Liver Life Challenge is the American Liver Foundation's official endurance program where dedicated athletes across the country use their passion and commitment to go the extra mile for the liver community. Run or ride with us in 2022. Visit liverlifechallenge.org to take on the challenge. And this is a fantastic challenge for all of you runners and bikers with great distances, and you can choose from them. So please get out there and get active. We've learned tonight it's important to stay active. So the legacy galas recognize individuals who've made an outstanding contribution to the liver community, fields of biotechnology, medical innovation, and philanthropy. Both galas will host patient families, medical professionals, organizational partners, and business visionaries in the healthcare, pharmaceutical, and biotech industries. To learn more about our galas occurring this May and October, please visit alfgala.org. American Liver Foundation advocacy represents more than 100 million Americans affected by liver disease. Together with volunteers and coalition partners, we advocate on behalf of liver patients, their caregivers, and all those impacted by liver disease for increased federal research funding, public health education, and improved patient treatments and coverage. To learn more or to become active in ALF advocacy, visit https://liverfoundation.org/advocacy. The American Liver Foundation has built a private Facebook support group community of biliary atresia family members and patients, moderated by an ALF staff member and a biliary atresia parent and patient, that will launch on April 6th. This community will provide a peer network, reliable information to biliary atresia families, and will have exclusive monthly educational programs from pediatric liver disease experts on different topics relating to the BA journey. This will also give the members an opportunity to ask experts general biliary atresia related questions. Share with your patients to be part of the community and access the monthly forums. Life with Biliary Atresia and American Liver Foundation Facebook support group. ALF will bring together up to 50 rare liver disease stakeholders, patients, caregivers, hepatologists, primary care providers, patient advocacy organizational personnel, and industry representatives for a 4-hour virtual roundtable to identify solutions for improving the health outcomes of individuals with rare liver diseases. This meeting will focus on answering the following questions. How can people avoid misdiagnosis and achieve earlier diagnosis and earlier connection to care? How can we educate more people about genetic testing and best address concerns about stigmatization? How can we reduce the patient burden and improve the overall patient experience? To receive an invitation for our first Rare Disease Summit, please email Ivory Allison at iallison@liverfoundation.org. All of the teams have performed exceptionally well this evening. I really want you all to pat yourselves on the back. These arguments were difficult. Again, we really talked about gray areas in liver disease, and every team did a phenomenal job tonight. I'm so excited about the future of hepatology. I can't even tell you. So thank you for sharing your hours. And I know it was many hours of research, elevating our understanding of this controversial and clinically important set of topics, and the benefits and drawbacks of each of your arguments, and devoting your time to improve patient outcomes. In our estimation, all teams are winners, and the real winners are the healthcare community, patients and caregivers, and the general public, because of you and because of your futures as well. But it is a debate, so now we have to let you know the winning teams. All right. Can I have an envelope, please? So, sorry, we're all doing this in real time, so it's very exciting for me. I feel like I don't know, like I have all the adrenaline that you guys have given to me through this Zoom. All right, so the winner of debate number 1 is University of Cincinnati. The winner of debate number 2 is Emory University. And the winner of debate number 3 is Ascension. Thank you all for your phenomenal work tonight. It's been a really exciting ride, and I really want to thank all of you. So poised, so bright, so inspiring. So thank you again for joining us tonight in our first Academic Debates Madness Week. And I think we can all look forward to some March Madness next year. We hope you enjoyed participating in and attending the event as much as we did. Tomorrow, both the participants and attendees will receive an email from us with a brief survey on your event experience, which will really help us in terms of making these debates continue to be phenomenal. We're also posting the link in the Zoom chat if you'd like to complete that survey now. We appreciate your feedback so we can make next year's debates even better. We hope you all will join us tomorrow for the last night of Academic Debates Madness. Thank you so much for attending tonight.